Hey, welcome back to another Kartzinel conversation with your host, Dr. Jerry Kartzinel. I'm a pediatrician. I've been working with kids for almost 40 years and kids on the autism spectrum and other neurological behavioral issue children for the past quarter of a century, 25 years, actually longer. I'm a little bit anxious today because you know why? We're going to talk about anxiety. Anxiety is something we have to talk about now because we just were speaking about language, and one of the big blocks to language is anxiety. And our kids have a lot of anxiety. You know, our children are very complicated. They have a lot of things going on simultaneously in their body that we have to address. They have bowel issues, they have sleep issues, they have food intolerances, very selective in the foods they will eat, picky, so they have nutritional deficiencies. Some of them have immune system dysfunctions. Some of them have psychiatric disturbances. Metabolically, they can have oxidative stress, mitochondrial disorders, metabolic dysfunctions for sure, endocrine dysfunction, and chronic inflammation and neuroinflammation. You know, when I was just doing general pediatrics, when a child came in with a ear infection, that's kind of all they had was an ear infection. Or if they had a diaper rash, a diaper rash, fix the diaper rash, and they go back to being Mr. or Mrs. Neurotypical. But our kids that I see in my clinic, I wish it was just a diaper rash that they came in. It was mom or dad. Actually, they have a lot of things. But what the parents say is, we want him speaking. And by the way, he's anxious. There's probably a genetic predisposition in some of the kids because many of my moms have anxiety, and not because they've just had a special needs child. They were, as I call it, nervous Nellies, like in kindergarten or in high school, junior high school. They've always had that anxiety. Some of them have been medicated in college for anxiety. So there's a genetic component. What our kids tend to do is take that genetic component and dial it up so it moves from functional to dysfunctional. But anyway, if you have anxiety, underlying behaviors can make it worse, like, say, constipation, that you're not moving your bowels. That's going to make your anxiety 10 times worse. It's a multiplier. We've talked about that before. But it's also going to impact your ability to communicate. It's going to seem to cause more repetitive behaviors, more stereotypia or stimming, tantrums. Yeah, anxiety can block you from being able to go to the supermarket, go out to restaurants, be in public places. Anxiety, I have kids where I call lovingly sundowner syndrome as it gets closer to bedtime. Anxiety prevents them from going to sleep. Anxiety wakes them up at 3 in the morning. They can be anxious over foods. You show them the wrong food and you're going to get anxiety. So anxiety is a big player in many of the children that I see. So therefore, we have to do our best to make sure that they're sleeping well, they're moving their bowels well. We've taken care of bowel infections. Um, why? Well, because all of these things going on inside of them will impact their senses, how they perceive our world through our eyes, our ears, how we taste things, how we feel things, how we smell things. Some of these kids have these tremendous abilities to hear everything and it bothers them, or they smell everything and certain smells, just a certain turn off. These are all impact, and it creates anxiety. It creates anxiety when they are exposed to these things that are not feeling good to them. So I guess we should say that anxiety is a maladaptive way that the body responds to what it perceives as a stressful situation. The key word is what it perceives. If the brain perceives a stimuli as being a very obnoxious stimuli, whether it be food or being told no or a sound, you're going to see a very maladaptive way that the child um, responds to it. And it can be screaming, tantruming, aggression. Putting the brakes on, they will not go into this particular restaurant. And it makes no sense because sometimes they can, sometimes they can't. So we're going to focus in on this anxiety and its relationship to the adrenal gland. Now, the adrenal gland sits on top of the kidneys, and you have two kidneys and you have two adrenal glands. And if the brain is perceiving a situation as a crisis, it will signal the adrenal gland to release adrenaline. And that is our fight or flight hormone. And that can trigger a lot of behaviors. One of them is anxiety, another one's aggression, whether it be self injurious behavior type of aggression, aggression where they're coming at you with their fangs, their claws, their hair pulling, their kicking, their headbutting, or property destruction. They break stuff. That's all adrenaline. But actually, we have two kinds of adrenaline we have to talk about. One is the adrenaline of a rabbit. I'm using a word picture here because of the fact that I don't have slides to show you. But if you think about a rabbit, it can go from peaceful grazing to full fight or flight like that. Because why? Everything wants to eat that poor rabbit. The coyote does, the snake does, the hawk does. So for its survival's sake, it has to be able to really react quickly. So that is adrenaline. Now, the other adrenaline that we have is the adrenaline of a lion. Now, nothing wants to eat a lion, but when she's off chasing the zebra for dinner, focus, kill. That adrenaline in our kids are my aggressive children. They're the ones that do the self-injurious behaviors or come at their caretakers, their parents, the teachers, other kids, and it's quite serious and quite scary. So adrenaline plays a huge role. Now, the rabbit adrenaline, what kind of symptoms do I see? How do I know I'm dealing with which adrenaline, the adrenaline or the noradrenaline? The noradrenaline is that of the lion. The adrenaline kids, they are my hyperactive kids. These are kids who are chewing their nails, chewing their shirts, mouthing everything, even mouthing their hand. Okay. They have terrible ADD. They can't focus. And they are just the busiest kids you've ever seen. They're my pickers too. My kids will get something and they'll just pick. So they're pickers, they're chewers, they're hyperactive, they're ADD, and they're not speaking. Okay. So what am I going to do with that? I've got a kid who produces a lot of adrenaline, and now you're asking me to fix that. I wish there was something natural that I could use, an herbal product or something, but I haven't found anything that really works for the kids. Oh, I know what they say out there. This is calming and this is that. But when you have a child who's releasing adrenaline, good night. It's going to be a very tough one to manage with herbs. So how are we going to fix this? How are we going to manage this? Well, before I tell you how, let me share a little story about Dr. Pavlov. He's a Russian scientist, and he had a very interesting experiment. You may have heard of it, Dr. Pavlov and his dogs. What he did was he had a bell that he would ring, kind of like a dinner bell. I don't think it was a triangle, though. And he would feed the dog. He'd ring the bell and he'd feed the dog. And he noticed something interesting. When he rang the bell, the dog would start drooling, salivate. In other words, there was a stimuli, the bell, and there was a physiologic response in the animal, the salivation, the drooling. Stimuli, physiologic response. Our kids have a stimuli. I'll just pick one. No. And the physiologic response is adrenaline being released, and they go into fight or flight, and you get the lovely behaviors that we've all come to know and love. But then Dr. Pavlov did something else that was kind of peculiar, kind of cool. He'd ring the bell, but he would not feed the dog. He'd ring the bell and he wouldn't feed the dog. Eventually, he noticed that when he'd ring the bell, the dog lost lost its physiologic response of drooling, salivation. Now let's take that into our kids. What if I stop feeding them? Huh? No. We ring the bell, we block the adrenaline. We ring the bell, we block the adrenaline. Eventually, the body learns to lose its response to the bell being rung. That bell could be told no, it could be bedtime, it could be going to a restaurant, it could be the baby sister walking in the room, or dad's voice, or mom's voice, whatever it is that triggers your son or daughter's behavior, no longer does it. In other words, we got a cure. It takes about a year. How are we going to do that, you ask? Well, the adrenaline goes into adrenaline receptor sites, much like the key goes into the front door lock of your house. It won't go into any of your neighbors, just yours. Adrenaline won't go into any neighbor's receptor sites, like the thyroid receptor site, the insulin receptor site, the testosterone receptor site, the growth hormone receptor site, and on it goes. It only goes into that. Now, what if I block that? What if I were to take something low tech like chewing gum and put that into the front door lock of your house? You put a key in, it won't go in. You have 100 keys, it won't go in. What if I put something in that receptor site that blocked adrenaline? Well, that receptor site has a name, and it's called a beta receptor site. And there's a whole class of drugs called beta blockers. Okay. And again, this is something that you would need a physician who knows how to do this work with you on it, because you can't get these things without a prescription, and you have to watch it. Now, what else do I do before I do that? Put them on a beta blocker. I track their heart rates. Why? Well, adrenaline, if you've ever had an adrenaline push, like somebody almost hit you in the car, it does a lot of things physiologically inside. It raises your blood pressure, increases your respiratory rate, it dilates your pupils, it can make you sweat under the arms, but it always raises the heart rate. Adrenaline always raises the heart rate. So I can watch their heart rates. So I generally get a heart rate before I start any of this beta blocker stuff, okay? And I can use it with that little pulse oximeter for $19.95 from the big pharmacy in the sky called Amazon. Or for the older kids who wear a watch, I can get like a Fitbit watch or an Apple Watch. I can track their heart rates all day with the watch. I can't usually do this because the kids won't wear a watch, but it's so cool when they do. I got great, data from the watch where I can see how their heart rates are going. They go to school, or sister comes in, or whatever the case may be. But I can watch those heart rates. Pulse oximeter, I just get that moment in time. If all I can get is a pulse oximeter, I grab their heart rate. And knowing what a normal heart rate in their age range is, I can then calculate if it's above it. So let's just pick a typical 8-year-old. A typical 8-year-old should have a heart rate resting, doing what he or she wants, around 80, 82. Okay. What if sitting there and it's 95, 96? And as soon as something doesn't go quite the way he or she perceives it should go, remember it's a perception thing, goes up to 120. I had a child sitting in my office in mom's lap, 147, just sitting there. She was a powder keg. She was ready to blow the first thing that doesn't go the way she thinks it should go. She is going to just blow up on us. Okay, so I watched the heart rates and established that, yes, it seems to be consistent. Your day is pretty much an adrenaline day. When you do the watch, very often it'll say, congratulations, you spent 8 hours and 43 minutes in fat burn mode and 7.5 minutes in cardio mode. It didn't know that you weren't cycling or jogging or running. This was just a kid, just living, just breathing. Yeah, that's what's happening. So, well, the pediatrician will say, obviously, your child has attention deficit disorder. Let's give him or her a stimulant like Ritalin, Cyalert, Focalin, or an amphetamine like Vyvanse or Adderall. What could possibly go wrong with putting a child who's already adrenalized on a stimulant? Yeah, I've seen that too. It's not a good not a good fit. They learn really quickly. That was a bad choice. Okay, so what do? We have to use a beta blocker. These are beta receptor sites where adrenaline goes, and I have to put something low tech in there. Nothing mentally intrusive now. I'm not making the brain do anything, but I put in a beta blocker and I titrate it, which means I dial in the dose. It's just perfect for your child until the behaviors improve, watching the heart rate go down. Now, remember, I'm not trying to lower the heart rate, though I will, because if the heart rate is being affected, impacted by adrenaline, when I block adrenaline's effect on the heart, it's going to go down. So I'm not making the heart rate go down intrinsically in the heart. I am keeping it from reacting to adrenaline that's floating around the system. That's how I manage that. And all of a sudden, the kids are calmer, they're more focused. Remember, I'm not in the brain. I'm not, with like a psychiatric drug. I'm just blocking adrenaline. And the next point, remember, we talked about eventually the body will learn not to use so much adrenaline to get through the day. So they seem calmer, more focused, not that ADD stuff. They're not hyperactive. And now we got a chance for language. What about the other half? The lion. Remember we had a lion? The lion are my self-injurious behaviors. These are the kids that are hitting themselves, they're biting their wrists, they're slapping their thighs, they're hitting their chest. These are kids who can be coming at you with their teeth, pulling hair, hitting you, slapping you, kicking you, headbutting you, or others. Their therapists, other kids, their siblings, the dog, yeah, even the dog, um, or they're into property destruction. They break stuff. That's the lion. That's not a beta receptor site. That belongs to the rabbit. The lion, that's an alpha receptor site. And there's a whole class of medications called alpha blockers, and I can use that. So very often, I have to have kids on an alpha blocker and a beta blocker, and I have a calm child. I'm not, the blood pressure is fine, the heart rate is fine, they're managing their day with all this adrenaline. Nothing else that the behavioral pediatrician or the psychiatrist or the neurologist is going to do to help the behaviors you're seeing unless we drill down to the root cause defect. And in some kids, and many of the kids, and the majority of kids with this anxiety, it's adrenaline. It's the strange artifact of the body just using adrenaline to make it through the day. Now, we don't know why. Okay, what happened? Why is this? You're only supposed to have adrenaline like right before a math test, or adrenaline when you come up to the plate in baseball, or adrenaline on your first date with somebody special. Why do these kids respond with so much adrenaline throughout the day? Love to know. And that's really cool and groovy. But my parents just fix it, just make it go away, make it stop. Okay, because this is really keeping him from being in school, communicating, learning, and growing with his therapists. Now, there are other things that we can do to help with the anxiety. Um, I do get lab work, make sure that their blood counts are normal, their thyroid is normal, the stool studies are fungus or bacteria. We can try to manage these behaviors with some natural things. Um, I don't see that much help with the typical anxiety approach with natural supplements like vitamin E, niacin, pantothenic acid, magnesium, phosphatidylserine. We could consider in some states medical cannabis. But again, I have to think if the issue is adrenaline, why would you throw all of these other things in? They don't manage adrenaline and its receptor sites. They mask it, okay? Now, what if it isn't adrenaline? What if it is really not adrenaline? They just have anxiety because they're missing an optimal genetic management of breakdown of adrenaline, catecholamine methyltransferase, and the such, then yes, we can use more of the natural things like I have some kids who do very well with certain forms of CBD oil. Um, Sometimes I have to think about, are they cortisol deficient? And maybe if I can measure cortisol or treat them with some hydrocortisone, which is bioidentical to cortisol. But as you can see, it's kind of complicated. I just wanted to give you an overview of an approach that really works in probably two-thirds to three-quarters of my patients who come in with those symptoms. All right, so that's what I had for you today about anxiety. Next week, we're going to talk about pans and pandas. Very complicated subject. There are a lot of myths out there. There's a lot of incomplete information, and people jump on that. I will tell you what's going on in my clinic and my approach to it. PANS, pediatric autoimmune neuropsychiatric syndrome. Pediatric because it's a kid. Autoimmune, that's the big word there. Neuropsychiatric behaviors, right? Disorder associated with something. We don't know what it is, we call it PANS. If we know it's strep, then it fits that cute little acronym PANDAS. So we'll be talking about that next week. Now, if you like what you're hearing, make sure you do a like, and we appreciate that. Share these conversations with other people you know that have children on the spectrum. Certainly, something I'm talking about is going to apply to your particular child, and I look forward to sharing that. But we have plenty of conversations to go. Guys, have a great, great week, and I look forward to sharing with you later. Now, you take care. Bye bye.